Oh, wow, a lot of people have already joined. Thanks everyone for being so punctual. This is the Department of Geriatric Medicine monthly grand rounds. Before I introduce our speakers, I just had a few housekeeping items to get out of the way. This CME activity is sponsored by the Hawaii Consortium for Continuing Medical Education, which is a joint venture between the Hawaii Medical Association and the John A. Burns School of Medicine. At this time, please enter the name and credentials of everyone viewing grand rounds for CME attendance purposes. As a reminder, evaluations are required for CMEs. You can find the evaluations by following the link in the chat at the end of this talk or at any time on our website or email advertisement. Your comments are very important to the planning committee, and we use those to plan future programs. As you know, all sponsors of CME are required to execute a conflict of interest policy. Speakers can tell us about real or apparent conflicts of interest, and all our presenters today have disclosed that they have no relationships with commercial supporters that could be perceived as a conflict of interest. So it's my great pleasure to introduce our three speakers for today. First, Monica Esquivel is a registered dietitian and certified specialist in sports dietetics. She did her Bachelor of Science in Food and Nutrition from San Diego State University, her master's degree and dietetic internship at California State University, Northridge, and a PhD in nutritional sciences at UH Manoa. Her goal is to improve the health and well-being of individuals and communities through food and community-centered approaches. And of interest, she's also an outrigger canoe paddler. Wow. Our next speaker is Sherry Gu Yoshino. She's a medical speech language pathologist with over 30 years of experience. She specializes in evaluation and treatment of swallowing disorders related to acute and progressive neurological diseases and head and neck cancer. She's also an instructor for the Communication Sciences and Disorders Department at JAPSOM and a clinical educator for graduate students. Her joy in work is implementation of a patient-centered interdisciplinary team approach in dysphagia management. Kimberly Lucas was a practicing pharmacist for 20 years before pursuing a career in dietetics. As a registered dietitian, she has practiced on the Big Island in a skilled nursing and long-term care facility. She currently works at Hawaii State Hospital with adult patients of all ages who have significant mental health needs. She finds joy in helping patients meet their nutritional needs with as much variety as possible. Please join me in welcoming our speakers.
Thank you, Dr. Masaki. This is Monica. We'll go next slide, please. So today, I do apologize. Kim is going to present a little bit more than she had bargained for. I'm a little under the weather. So our learning objectives for today are to share the benefits of the International Dysphasia Diet Standardization Initiative, or the IDDS framework, define those levels of the IDDS framework, as well as to share the roles of the registered dietitian nutritionist, or RDN, speech language pathologist, in determining the optimal texture and nutrient modifications for individual patients. Next slide. And so we have no disclosures, and I'll pass it on to Kim.
Aloha. So what is IDDS? As Monica's mentioned, it's the International Dysphasia Diet Standardization Initiative, and it was founded in 2013. It is a global texture modified diet standard for individuals with swallowing difficulties in all cultures, care setting, and ages. IDDS consists of a continuum of 8 levels from 0 through 7, where drinks are from levels 0 through 4 and foods from levels 3 through 7. Looking at the pyramid, you can see that levels 3 and 4 with the food and drinks overlap, and we will discuss this when we get into the individual levels. Looking at the framework, you can see that each level has words, numbers, and colors associated with it. The initiative, founded in 2013 with members including physicians, dietitians, speech language pathologists, and food scientists from across the globe. The goal was to create an international standardized terminology, which has so far been adopted into 30 countries and 13 languages. And it has clear and objective guidelines for diet modifications, which was most recently updated in 2019. The IDDS framework provides common terminology to describe food textures and drink thicknesses, which is so important as there has been much confusion around diet names and what is served on these textured modified diets. For example, fine chopped, minced, is it the same thing? Is it different? And that can depend on the facility. The framework includes food and drink descriptors, along with instructions for easy, reliable, and accessible methods to test different foods and drinks. And these testing methods require only fork, spoon, and syringes for liquids. Next slide, please. The goals in the next group of slides is to familiarize you with the IDDS levels, the terminology and descriptions. Previous terminology could be confusing as not everyone globally, or even in the next facility down the street, described modified foods and liquids in the same way. IDDS helps answer these questions, and it revolves around the food, the shape, the texture, the moisture level, and then the menu dealing with transitional items with dual textures. Next slide. When you're using the IDDS, be sure to use at least two identifiers, the words and the numbers. For example, level 7, regular, or level 0, thin. Level 0, thin, flows like water. And this is the default of a regular diet. When a person comes in with no swallowing difficulties at all, regular level 0 is going to be the default diet. Next slide. Slightly thicker level 1 is thicker than water, but can still flow through a straw. This is a new group from previously used terminology and is most commonly used with infants to thicken formula, but still be able to drink from a bottle. It can also include some nutritional shakes. Next slide. Mildly thick, or level 2, is similar to nectar thick in the older terms. It can be sipped from a cup or straw. However, some effort is needed to drink this thickness using a standard straw. They pour quickly from a spoon, but flow more slowly than level 0 or level 1. Some fruit nectars, supplements, and thickened liquids are examples of this category. Next slide. Thick, or level 3, is also the same as liquidized foods. This is that crossover category that we mentioned on a few slides earlier. As both the food and the drink have the same thickness and the same properties when swallowing, and the same descriptions and testing methods. Examples include soup, cream of wheat, and gravies. This is similar to honey thick in older terms. So this is the moderately thick for the food portion. The above 3 levels can all be tested using a 10 cc syringe, allowing the liquid to flow out over 10 seconds. For level 0, no liquid would be left in the syringe. And for level 3, approximately 8 milliliters would be left in the syringe. Next slide. Level 4, or extremely thick liquids, is also the same as pureed foods. And they are connected in the same pyramid. It does not require chewing, and it must be a smooth and moist texture with no lumps and is not sticky. This level is too thick to flow through a syringe and is tested using a spoon. Next slide. Does it slide easily off the spoon? If it sticks to the spoon, as the peanut butter is on the right-hand side, it is not appropriate for this texture. Next slide, please. Level 5 is minced and moist. It does not require biting, and minimal chewing is required. These foods can easily be mashed with just a little pressure from a fork. The particle size restrictions of 4 millimeters wide by 15 millimeters long for adults is approximately the width between the tines in a regular fork. This level encompasses ground, minced, diced, and finally chopped from various institutions. Next slide. Level 6, or soft and bite-sized, is tender and moist. They can be mashed or broken down with pressure from a fork and require a moderate amount of chewing. Particle size restrictions is less than 15 millimeters, or roughly half an inch. It can also be noted it's the size of an average thumbnail on an adult, or it's no larger than the width of a fork. This is formally referred to as chopped. Next slide, please. And as you can see, just by using a little bit of pressure and the thumbnail is slightly blanched, this can be mashed down. They do note that they don't recommend specific foods. For an example, a very unripe banana is not necessarily going to be able to be mashed with the fork, whereas a very ripe, soft banana can be mashed easily. So being able to put specific foods into categories is more challenging, and that's why they have the testing methods. Next slide, please. Level 7 has 2 subcategories, and this is actually another kind of newer category from the older diet terminology. And the first is easy to chew. So while they're normal everyday foods, they are soft and tender of texture. It can easily cut or separate it with the sides of a fork. In this texture, the size of the food pieces is not restricted, and therefore it is not intended for people with a high risk of choking. Foods that are tough, hard, chewy, fibrous, stringy, or foods that have seeds, bones, or gristle are considered non-compliant with this level. Please. As you can see, just by slightly blanching or cutting with the sides of the fork. This is good for people who may have poor dentition, but do not have any issues with swallowing. Next slide. Level 7 regular is your normal everyday food. It includes transitional foods, which are foods that start out as one texture and change into another, specifically when moisture is applied or temperature is changed. For example, ice cream, which may be solid at cold temperatures, but it will melt into a liquid in your mouth. Additionally, bread is only recommended on level 7, unless assessed by a clinician. And this is where referral to your speech language pathologist can be very important, as bread is associated with choking or airway blockage. Sometimes bread may be based on a person's preferences and wishes and according to their goals of care, or within a person-centered care approach, and this must be documented well. Additionally, mixed consistencies are not recommended on the IDDS diet except for level 7. For example, cereal and milk. A person may aspirate on the liquid while chewing the solids. Just like bread, mixed consistencies need to be assessed by a clinician. Next slide, please. So how does one know if the foods or liquids are meeting the level guidelines? Well, by using the testing methods provided by IDDS. It is recommended to have an in-service training by a dietitian or a speech language pathologist who's familiar with the guidelines. At my former facility, the speech language pathologist would provide in-services to the kitchen staff, the CNAs, or any other caregivers providing food and beverages to the patients. And as you can see, you've got the fork and the spoon and the different levels, and there are guidelines as far as whether the puree needs to stay on this. The puree does not flow through the tines of the fork, however, it slides easily off the spoon. Next slide. And this is just some more testing methods for the various levels. Next slide. Back over to Monica.
Thanks. And so we thought it would be, we wanted to share the IDDS framework and give everyone an overview and kind of that framework, and then sort of have a little bit of the rest of the time to discuss an interdisciplinary team approach to providing care for a patient. And so we present patient HK, a 92-year-old female who is diagnosed with dementia, but is able to communicate some basic needs. Pertinent medical history, prior medical history includes coronary heart disease, obesity, diverticulitis, type 2 diabetes, and dehydration. Other relevant information, HK is a resident at an assisted living home. She has family that visits daily. She's experienced some recent weight loss that is non-significant, but has shown some disinterest in eating and a decreased inability to self-feed lately. Next slide. And so I guess this is where we wanted to sort of start the discussion about, as a physician, how one might start the process of determining the most appropriate orders. And so we thought we'd try to start with our physician participants, or Dr. Masaki, what your perspective is on this patient, what you see your role is, and yeah, how you might begin providing care. And then afterwards, we'll go through our team of Sherry and Kim to discuss their roles. So,
Monica, could you put up the previous slide, please, so that the physicians can refresh the memories? Okay, great. Thank you.
Thanks, John.
Any of the physicians want to chime in?
I see Lauren Okamoto.
From Dr. Okamoto, she's asking about first task goals of care. What matters to the patient? Great point. Any other thoughts from the physicians? Some thoughts about ask if she gets tired when she eats, ask if there's difficulty swallowing, and then review if there are any medication changes. So these are 3 comments that came in.
Good. So good. Additional questions to ask. Anything else? Anyone? Oh, oral exam, doctor.
Well, you
Dr.
know,
Takenaka said oral exam, check if there are any other physical limitations to self-feeding like arthritis or tremor.
yeah, I was going to say decreased ability to self-feed. What does that mean? Is it, you know, the hand? Is it oral, or is it apraxia?
Okay.
I think so in this case, we'll go on. Yeah, food.
Another comment was about food preference from Dr. Lubimir. Any other thoughts, anyone? Okay, maybe our panel can move forward then. Oh, one more, ask about mood. Okay.
Yeah, thank you. John, if you could go forward. One more. There you go. Okay, Kim.
Okay, so we'll share some of the dietitian's perspective. So our goal is to reduce aspiration and choking risks while mitigating negative healthcare outcomes such as dehydration and malnutrition. So as the level of food or drink modification is increased, the level of intake generally decreases. And for example, providing a level 3 beverage is more challenging for the care staff than providing a level 0. So instead of just going to the water pitcher and pouring out a glass of water, they've got to make sure they take the time and thicken up appropriately. So that beverage may not be offered as often. And additionally, level 3 drinks may not be as palatable to the patient, and they'll have a decreased consumption In both cases, especially if they're combined, dehydration is a significant risk. Likewise, modification to level 5 or level 4, so that's going to be your pureed or your minced diet, may also result in a decreased consumption and increase your risk of malnutrition. So determining the why of the diet order is critically important, and this is where the documentation is so necessary. So not necessarily referring to the previous patient, but just in general, is there a tooth infection causing pain and the diet only needs modified until the dental visit? So maybe the diet only needs modified for a week and not permanently. Are there certain foods that cause issue? So diet order may be specific to provide, say, a regular diet level 7 for all food except for meat and protein. And the meat and protein is to be provided at level 6, soft and bite size. Because the patient may get tired with the chewing of the meat, or their dexterity for cutting up the meat is not as strong. Is there impaired swallowing, and can it be inspected to improve? So a stroke patient may start out NPO and on enteral nutrition, but with time and intervention by a speech language pathologist, they may progress through some or all of the levels. And as their level increase, then their risk of malnutrition decreases. Is there evidence of dysphasia? Have they been evaluated by a speech language pathologist? This is very important, as they may or may not be able to safely swallow bread or other mixed textured items. And to the point earlier, are their favorite foods? And this is where it's important to involve the family, involve the CNAs and other staff. CNAs in particular can provide quite a bit of information on patient food preferences that they may or may not be able to communicate to you. Next slide, please. So there are actually 2 components that a dietitian will evaluate. And so first is going to be the texture modification component, and the second is going to be the therapeutic component. So as mentioned previously, she had congestive heart failure, she had diabetes, and as therapeutic modifications increase, intake can also decrease. And so just trying to balance that out. Do we need to restrict all of the sweets and the carbohydrates, or do we need to modify that with medication and allow her to have more food? I currently have one patient who is at risk for pressure ulcers because his body weight is only a BMI of 15. And so even though he has significant diabetes, we're actually trying to modify that with the insulin intake, with what he'll actually eat. And his preference right now is pureed pumpkin. So just trying to balance the carbohydrate, we can add proteins and fats to that to help decrease, the insulin levels, but also without the calories, he's going to continue to be at risk for pressure injuries. And it's worth to note that goals in long-term care and acute hospitals are very different. So acute hospitals we're generally much more restrictive. For example, for a renal patient, we may restrict sodium and potassium and phosphorus and fluids. However, the more food categories restricted, it's also a likely decrease in food consumption. Whereas long-term care is more reflective of a home environment, and liberalization is key. So instead of a 2-gram sodium diet, we may simply do a no added sodium. There's concern for weight loss and sarcopenia in this population. And so also, as mentioned, goals of care must be taken into account. So balancing the quality of life with the quantity of life. And in the picture added, this is actually making minced bread. So the bread is pureed into breadcrumbs, which is put into a mold. And we've added, they've added some liquid to make it moist, added the sandwich topping, added more breadcrumbs onto the top. So while it is safe to eat on a minced level diet, it has the appearance and a taste of a sandwich. So just working with the patients to determine what some of their favorite foods are and balancing that with what their abilities are, I think is critically important. Next slide. So I will turn this over so Sherry can share her experiences.
Okay, thank you. Hi, everyone. Thank you for joining today. A referral to speech language pathology to determine if the swallowing is impaired will entail, first of all, a clinical swallow evaluation, which is really designed to assess the patient's cognition and communication, their interest and endurance, as well as their swallow function for safe and efficient PO intake. An instrumental swallow evaluation may be considered, particularly if a patient has a medical condition that puts them at high risk for dysphagia or aspiration, including populations, those with head and neck cancer, perhaps with ALS, as well as Alzheimer's disease. Or if the patients report or present at the time of the clinical swallow evaluation signs of choking, wet vocal quality, coughing or throat clearing during meal times, or they report symptoms of foods or liquids sticking in their throat. Common instrumental swallow evaluations include a modified barium swallow study. That's that first image that looks like an X-ray, which is really a moving video of the patient's swallow, as well as the colored image down below, that is a fiber optic endoscopic evaluation of swallow, and it's really looking directly at the larynx as the patient swallows tested foods and liquids. Both provide information on the patient's swallow, as well as the risk of aspiration on, again, tested foods and liquids. And on these studies, we get to objectively assess benefit of compensatory strategies as well as no benefit. In the case of HK, our case study, prior to the clinical swallow or prior to workup, caregivers were feeding her pureed foods and thick liquids, like thinner than yogurt, and her meals took at least 45 minutes because of her refusal, as well as the environment just not being very pleasant for her in terms of eating the foods. Findings on the evaluations indicated that she did aspirate thin liquids when she drank them by successive sips, prolonged chewing, as well as food residue on her tongue and in her pharynx. She was noted to swallow pureed and mixed moist foods, as well as mildly thick liquids efficiently and safely. In addition, with pacing cues, she swallowed thin liquids by individual sips without aspiration. Next slide, John. Okay. Evaluation findings, they're one factor in determining the treatment plan. And it's really important to consider and balance other factors, such as the patient's perspective and preferences, the patient and family's values and their goals of care, and what quality of life means to them in the context of the underlying disease, potential for improvement, and the caregiver and the environment of which the care is provided. Depending on the patient's disposition, treatment options may include exercise-based kind of treatment where exercises are used to perhaps improve declining functional physiologic reserve that impacts swallow safety and efficiency. Treatment can also include various compensatory techniques. Postures, for example, specifically chin down, can be used to, what it does is changes the relationship of the anatomy and places the tongue base closer to the pharyngeal wall to eliminate or reduce residue in the pharynx. Likewise, a chin tuck swallow maneuver requires, the posture is chin tuck. And then the swallow maneuver would be an effortful swallow. And that requires the patient to swallow hard. And it increases tongue-based movement and then can also eliminate residue in the pharynx. Often environmental management and feeding guidelines are offered, really meant to create a meal setting that supports the patient's swallow safety as well as independence, like sitting upright, offering tactile cues to optimize self-feeding if it's possible, as well as verbal cues to pace sips and swallows. A last compensatory approach, and that's what we're talking about today, is really diet texture modifications. IDDS really helps us in standardizing terminology across settings and places. However, it's really understanding our patient-specific needs and preferences that guides individualized recommendations. And if a patient has a specific request or preference that doesn't fit well into an IDDS level, the SLP can assess the patient on very specific preferences or help generalize what is known on the patient swallow based on the clinical or instrumental swallow evaluations to offer options in collaboration with a dietitian. As you notice, treatment options vary and they can be complex and they may not be appropriate for all populations as well as all stages of disease progression. Therefore, really early intervention with interdisciplinary care can really support early diagnoses, which then guides management to optimize health as well as the patient's quality of life. Next slide, John, and I'll hand it over to Monica.
Thanks. And so I'm just sharing a little bit more about that family perspective and the patient perspective. Some of HK's favorite foods were, papaya, banana, ramen, the tuna sandwich, fruit juice. The family's goals are really for her to enjoy eating without aspirating. And with the progression of her dementia diagnosis, they're really focused on balancing kind of end of life care with that and understanding that, but also maintaining quality of life, safety, as well as sustaining nutritional status and health. And so we bring up some of these favorite foods because it was a unique kind of a unique role the speech language pathologist can play in helping to modify some of these levels. So we have these really standardized levels for the IDDS diet. But Sherry, could you share a little bit about how perhaps in the case of HK, we might be able to accommodate the tuna sandwich or even maybe the ramen preference for our patient?
Sure. Either papaya and banana, they fit well into IDDS levels. Ramen and tuna sandwiches, as well as others, we look at comfort foods, can be really desired by patients. We mentioned earlier that mixed consistencies are most challenging or can be challenging for patients. And so in the case of a ramen, again, I feel like these kind of clinical decisions and problem solving really engages the team as well as the patient and their family. And so one option would be, for example, to separate the ramen from the broth and then modify the ramen noodles so that they're a moist and minced texture. And then she could sip on the ramen soup separately by individual sips. For a tuna sandwich, Kimberly mentioned how a dysphagia sandwich can look like. Okay, but the other is when we're engaging the patient and family, maybe it's not the bread that they particularly like, but they like the taste, or they might like how, the texture of tuna that we could capitalize on. And so therefore, the patient could have the tuna without the bread. Okay. And then for fruit juices, we talked about that on the studies, that something that was thicker, mildly thick, something more nectar, but it didn't need to be as thick as a yogurt texture, could optimize her swallow safety as well as her joy of fruit juice. So it can be thickened, not as thick as to what they were doing in the care home, but that it could be thinned down or be a mildly thick, as well as with support of a caregiver to cue her to swallow fruit juices or water with a sip and swallow. So individual sips versus successive sips.
Thanks, Sherry. And something that I think I learned, and Kim, maybe she knew this from her practice, we learned from Sherry, is that in some cases you can do testing of certain foods to see if there could be, within the texture modification, there could be some clarification that certain foods have been tested and are safe for an individual patient. So taking the IDDS framework and then also individualizing it to a patient's physiologic abilities to swallow. And so I think that was the end of what we had put together. So the next slide, John. We were hoping if anyone had any questions, we could discuss some questions at this time. We have the slides. I've sent them over to be shared with you all, so you have the terminology and the resources that were shared available. But I'd like to open it up if there are any questions from the audience at this time.
Thank you so much to all our speakers for an excellent presentation, very practical with a case presentation as well, which we love. Does anybody have any questions? You can unmute yourself and ask the question, or you can put it in the chat box, either one.
No questions, but thank you for doing this for us. I actually, for me and my facility, the issue is the people in the kitchen are not necessarily well trained in terms of diet modification. So the people who are preparing it often ask the medical director questions because they have a hard time interpreting the diet orders. And I think maybe you answered my question where I might have to have the speech language pathologist do an in-service for them, but it seems recurrent where the kitchen staff are not medically trained, so they have a hard time understanding the ST lingo. And they're asking us as physicians, like, what does this mean and how do I know? In your talk kind of showed us some tricks about how to determine whether using the fork to smash the, but translating that into actual food on a plate is where I think is difficult for us in the facilities.
I think Sherry shared I think that the IDDS framework, I believe, structuring trainings around some of those guidelines would be really helpful. And, you can adapt it to the different types of foods on your menu, and you can really see like, okay, for all of the foods in this category, like, can you mash it with a fork? And then kind of having different food textures. But Sherry, do you want to share a little bit about your experience at Kaiser and how this was rolled out there to help improve the training? Yeah.
The dietitians at that facility really took the role of implementation. And it wasn't, it took steps. It could include, for example, not only training, but even modification of the diet orders, right? And in terms of the kitchen staff being trained in the new textures, nurses aides who are going to be delivering the trays, and then again in collaboration with speech language pathologists, because there are some differences. The idea is meant to be standardized, but there are some, for example, it can be individualized to some degree to account for pediatric as well as adult populations. It was a long process. I mean, they really follow the guidance of IDDS of when to start and what were the stages of implementation.
Thank you. Yeah, in our facilities, the other issue is, they're doing like activities, and the CNAs are the ones grabbing snacks for the patients during activities, but it's not necessarily like passing through the kitchen because there's a snack cart. So even for that, we're kind of like, ooh, are we feeding them appropriate? Sometimes we have, it seems like we're guessing or they're guessing, and yeah, that question came up. Even nursing staff keep asking for clarification, but I can see it being a long process that requires a lot of interdisciplinary team members to sort of standardize this. But thank you. Thanks so much.
I think the last group of people, especially here, that needs training is family. Family,
Yeah.
we love to bring our loved ones their favorite foods and mean no harm, in trying to help them to eat and enjoy food. But, I think family is the last kind of wheel of that barrel for training, the wheelbarrow. Thanks.
I think Dr. Wen had a question. Dr. Wen, do you want to ask your question?
Yeah, I don't know what you think about that water protocol. That is that, they may be on purees and nectar thick on other drinks, but water, since it's pretty inert, is that okay? Because some people otherwise get dehydrated. And what your thoughts are on that?
Dr. Wen, are you talking about the like a Fraser water protocol? Yeah, it's really stringent in terms of application, because the patient needs to have good oral hygiene if they're drinking water, and that it's taken after meal time, right? So if there's any kind of residue in the pharynx, that if they aspirate, they're not aspirating the food and liquids. The others, original data was based on patients who were pretty hardy, so they're outpatients. Inpatients might be maybe, they may not have the reserve. I do think it calls for some individualization, because a patient who's not going to drink any form of thick liquid, we're not helping them by restricting them from thinner liquids.
Thank you for that. Dr. Colgan, would you like to unmute yourself and ask your question? If not, I can read it out for you. She wants to know if there's evidence for improved outcomes like weight maintenance and reduced aspiration with texture modification, or is it more just for symptom management? So basically with this texture modification, is there evidence for improved outcomes like weight and reduced aspiration?
That's a great question. And the data is still evolving. There's no clear indication. I think the data is still evolving, and we're lacking in terms of whether or not diet textures will actually reduce aspiration or eliminate aspiration pneumonia. A consideration is that, looking at the patient's symptoms, and also it's not only aspiration, but a thought is at risk of choking if they are they're given regular food textures and not chewing for various reasons, whether it's because of no dentures or ill-fitting dentures, or because of an oral pharyngeal dysphagia. And I do think that our evaluations, whether it's a speech language pathologist, the dietitian, and we also think about other disciplines like occupational therapy, that the evaluation is dynamic and it's not a kind of like a one and done. We should really be following the patients to see what their response is like to any of the interventions, including texture diet modifications.
I could
Thank
just
you.
share, HK was an example of a family member of mine. And, we had, as a family, we were observing these declines in her intake and my grandmother's intake and wanting some sort of intervention and thinking about it. And it really is, I want to emphasize what Sherry said, is observing the changes in PO intake from a dietetic standpoint. The team is really monitoring the PO intake, the percentage of meals being consumed, and monitoring weight and some of these things, and providing the intervention based on all of the signs and symptoms that are being observed. And so in that case, there is the evidence for the dietitian's intervention and this ongoing assessment is strong. We know that early nutrition interventions that improve PO intake can decrease malnutrition and subsequently mortality.
I would
Thank you.
add to that, anytime that we do make a texture or dietary modification, that it's important to increase the frequency of monitoring. I know in a lot of facilities we'll do monthly weights, whereas if they have a texture modification, you might increase that to weekly weights for 4 weeks, just to make sure that when we change from one texture to another, that either their weight increases as we want it to, or to make sure that there's not a significant weight loss that we need to revamp what the modification that we made was.
Thanks very much. Any other questions from anyone? I had a family member too, and this goes back to Lauren's initial comment about the first question to ask is what matters to the patient. I had a family member who had a stroke and was put on a pureed diet with thickened liquids and was absolutely miserable. And after discussing it with her and the rest of the family, I talked to the nursing home where she was at and said, please liberalize the diet for her quality of life, if nothing else. And they made me sign this document basically saying that they don't have any liability, which I was willing to sign. But then they did put her on a chopped diet and they put her on regular liquids, and she was a lot happier and actually started eating, which she had stopped doing with the puree. She made me taste it. When I went to talk to her about it, she said, try this, see how awful it is. And I had to admit it was pretty bad. So yeah. For her, quality of life was more important, and we all agreed with her, and we backed up her decision to choose her diet despite the risk. She was willing to take that risk.
Yeah, absolutely.
Thanks. It's interesting because one of the facilities we assumed like medical directorship at recently, they had a policy in place that their staff would not feed a person if the diet didn't match what the ST recommended, even though it was related to like end of life and goals of care and the patient wanted that for comfort. Their staff didn't feel comfortable feeding the patients. So we have to do a lot of education for them to accept that this is, what the patient wants and goals of care, and they wanted to eat whatever, papaya or whatnot, and they understood their risk. But it was a kind of a hard thing for the facility based on their culture to accept. It was interesting to see that, it's still out there.
Our experience,
go ahead.
Our experience was also that, if our family member wasn't there sitting at mealtime to really help and assist with the meals, it was hard for us that facility where my grandmother was at, it was hard for us to get a staff person to sit and do that with her. And we found that was like one of the most important things, was just sitting with her and kind of assisting. But yeah, it is interesting, the culture of the different places and what becomes the norm, and how to try to break people out of that. Sorry, come on.
There's a comment over there. It looks like it's from me, but it's actually Dr. Blanchette, because I sent her my link.
Okay.
She said communicate. She wanted to just remind us communication about modified diet or texture between transfers is very important. Sometimes this information is lacking. And I think all of us who work in nursing homes can attest to that. Sometimes the communication from the hospital to the nursing home, or even from the nursing home outside, needs to be very clear. Good point, Dr. Blanchette. Thank you.
And I also think that's where, like, you know, I think Kim had mentioned differences in facilities, what they use as their order terminology. And that's where the IDDS language, if you know that a level 7 is a level 7, here is, there is, everywhere, that is also really beneficial.
Exactly the problem we had. Like, they're calling the doctors like, what is this level, whatever, how do I translate it into the facilities protocol? And then the chef doesn't understand how to create the menu. And oh my gosh, yeah, definitely that. Different lingos, because we're not all standardized yet. Yeah. Thanks.
Thank you. Any other questions from anyone in our audience? These questions have been very interesting and helpful. Okay, if there aren't any more, thank you again to our speakers for today. And Michaela has put the link for evaluations into the chat box. So don't forget, if you want CME credits, you do need to do the evaluation to get your CMEs. Thank you again, everyone, for joining us. And we hope to see you again next month.
Thank you.
Thanks to our speakers. Okay, bye-bye.